Hi and welcome to my lecture on the normal menstrual cycle. To download my lecture deck, please go to my WordPress site, Docina Obigaine. Reference for this lecture is Comprehensive Gynecology 7th edition. And here's the outline of my lecture. So before we start the lecture proper on the normal menstrual cycle, let me just go through a review or a quick review of some of the basic concepts that will help us understand more the normal menstrual cycle. So let me start first with reviewing ovarian folliculogenesis. So as you can see here, we have the primary oocyte, which is surrounded by a single layer of granulosa cells, and this unit is what we call the primordial follicle. Okay, so even in the absence of stimulation by gonadotropins, some primordial follicles will develop into the primary follicle. So as you can see here, this is also called the preantral follicle, and at this stage, there are already multiple layers of the granulosa cells, as you can see here. So the development of the follicles to this stage appears to be relatively independent of pituitary control, but is probably influenced by intraovarian non-steroidal processes that remain to be understood. Now, the development to this stage occurs during the non-ovulatory stages of childhood, pregnancy, oral contraceptive use, as well as during ovulatory cycles. Now, with the formation of the antrum, as you can see here, or the cavity, the follicle is now referred to as the secondary follicle or the antral follicle. Now, this enters the final stages of folliculogenesis, characterized by the transition from intra-ovarian regulation to a major control by the hypothalamic pituitary unit. This requires the presence of the characteristic increase in gonadotropins, particularly FSH, that occurs in the early menstrual cycle. So we will further elucidate this later in the coming slides. Now, the development process from the primary follicle or the preantral follicle to the secondary follicle or antral follicle, and lastly to the mature preovulatory follicle. So this takes about 1 year to complete. Okay, so only about 400 follicles complete this process, whereas the majority of follicles undergo programmed cell death. So this is a very nice picture depicting the life history of ovarian follicles. And as you can see here, there are different stages through which these ovarian follicles go through. So we can see here endowment and maintenance, recruitment, maturation, and atresia. So as you can see here at the start of the life history, we have a fixed number of primordial follicles that are endowed during the early life, and most of these are maintained in the resting phase or in the resting state. Now, growth of some of these dormant follicles is initiated before and throughout reproductive life, and this is what we call recruitment or initial recruitment. Now, the follicles develop through primordial, primary, and secondary stages before acquiring an antral cavity, and that is what basically what you've seen in the picture from the previous slide. Now, at the antral stage, most follicles undergo atresia. However, under optimal gonadotropin stimulation, particularly FSH, so a dominant follicle will be selected, which will undergo ovulation. Now, the menstrual or ovulatory cycle is actually an orderly sequence of events involving the remarkable coordination or communication at several levels of the HPO axis, or what we call the hypothalamic pituitary ovarian axis. And this also includes the participation of some of the organs that are outside of this HPO axis, particularly the uterus. Now, the proper functioning of the HPO axis is very, very crucial in stimulating or instigating the orderly sequential events in the menstrual cycle, such as the folliculogenesis, ovulation, formation of the corpus luteum, and eventually endometrial shedding or menstruation. Now, when we talk about the HPO axis, it is very important that we understand the negative feedback loop and the positive feedback loop. So let's first talk about the negative feedback loop. So as in other endocrine systems, the major ovarian to brain pituitary feedback loop is inhibitory. So that's what we call the negative feedback loop. So this is where the steroid that is secreted by the target organ, which in this case, of course, is the ovary, regulates the hypothalamic hypophyseal unit to adjust the production of GnRH and the secretion of gonadotropins appropriately. So we have here the estradiol 17 beta, which is a potent inhibitor of GnRH and gonadotropin secretion. Now, the threshold for the negative feedback action of estradiol is such that even small increases in the levels of the hormone induce a decrease in gonadotropins. Okay, so the levels of LH and FSH during the follicular phase vary in accordance with the changes in estradiol concentrations that accompany maturation of the cycle or of the follicle. So, as circulating estradiol levels increase during the follicular phase, such as you can see here, no, as the follicle grows and matures, so does the estrogen or the estradiol level increase. No? So as the estradiol level increases, this sends a negative feedback to the hypophyseal or the hypothalamus pituitary unit to decrease its production of GnRH and decrease its production of gonadotropins, mainly LH and FSH. So the estradiol negative feedback loop acts to decrease the LH secretion rapidly, mainly by controlling the amplitude of each LH pulse. Now, most evidence suggests that this action is secondary to inhibitory effects of the GnRH pulse, most probably relayed by estrogen receptive kisspeptin and possibly GABA neurons. Now, progesterone, on the other hand, is noted to be at a high level during the second half of the menstrual cycle. So, this also exerts an inhibitory effect on the gonadotropin secretion. But in contrast to estradiol, progesterone affects mainly the GnRH pulse generator by slowing the frequency of pulses. Okay, so this effect is responsible for the significant decrease in the LH pulse frequency, which is observed during the luteal phase of the cycle. So what about the positive feedback loop? So at higher physiologic concentrations, estradiol can also exert a separate stimulatory effect, or what we call the positive feedback loop, on gonadotropin secretion. Now, this feedback loop, or the positive feedback loop, is dependent on rapidly rising estradiol levels during the follicular phase of the menstrual cycle. And this is also in combination with a small but significant progesterone rise, which are both produced by the mature dominant follicle and responsible for the generation of the pre-ovulatory LH and FSH surge. Okay, so when we talk about the positive feedback loop, so the increase in the estradiol levels during the first half of the menstrual cycle leads to an increase in the luteinizing hormone and an decrease in the FSH. So this is what we call the LH and the FSH surge. Now, the LH surge in particular will signal the ovulation. Okay, so the positive feedback loop is observed in many species, and this serves as a critical signal to the hypothalamic pituitary axis that the dominant follicle is ready to ovulate. So the coordinated events in the menstrual cycle actually involve two main organ systems, and that's the ovary, where the follicular growth, ovulation, and the formation of the corpus luteum occurs, and of course, the uterus, particularly the uterine lining or what we call the endometrium. Okay, so basically we have different phases of the menstrual cycle, and we call them by different names depending on what cycle you are talking about, whether it's the ovarian cycle or the endometrial cycle. But don't worry, these terms are often interchangeable. So the first phase is the follicular phase, this one, and this phase mainly involves the growth of the follicles. Okay, so this is the cycle that involves, or the second half of the cycle that involves the formation of the corpus luteum. Okay, and in between them, we have ovulation. Okay, so for the endometrial cycle, we have the first phase, or the first half of the menstrual cycle, is the proliferative phase. So the follicular phase corresponds to the proliferative phase. So both of this follicular phase and proliferative phase both refer to the first half of the menstrual cycle. So they are coordinated. Okay, sometimes these two terms are interchangeable. And the second half of the endometrial cycle is what we call the secretory phase. Okay, so the luteal phase corresponds to the secretory phase of the endometrial cycle. And at the end of this cycle, we have the menstrual phase. Okay, some numbers to remember. So the mean duration of the menstrual cycle is 28 plus or minus 7 days, and the length of the follicular phase is more variable compared to the luteal phase, and the length of the luteal or secretory phase is just 14 days. Why 14 days? Because this corresponds to the lifespan of the corpus luteum, meaning the corpus luteum lives for 14 days, and that's why the length of the luteal phase or the secretory phase is just 14 days, or fixed to 14 days. Now, the mean age of menarche is approximately 12. The mean age of menopause is approximately, or in the range of 45 to 55 years old. And the menstrual cycle length is most variable in the 2 years following menarche and preceding menopause, because these are the times of the life of the woman during which anovulatory cycles are most frequent. Now let's first talk about the follicular phase or the proliferative phase, and this is the first half of the menstrual cycle. Okay, so the follicular phase is subdivided into 3 periods. First is the successive recruitment of a cohort of antral follicles. This is followed by the selection of a dominant follicle, and the third will be the growth of the selected dominant follicle. Okay, so for the recruitment of a cohort of antral follicles, FSH, or the follicle stimulating hormone, is actually a very important hormone because this provides the critical signal for the recruitment of a cohort of preantral follicles, and this is what we call the cyclic recruitment. So this cohort of preantral follicles is this one. No? So this is composed of about 3 to 7 secondary preantral follicles. Now, FSH signal is the major survival factor that rescues these follicles, or this cohort of secondary preantral follicles, from their programmed cell death, or what we call atresia, and then this also allows them to start growing and increasing in size and begin to synthesize steroids. Now, at this point, let me introduce to you the concept of ovarian reserve. Ovarian reserve is actually the number of antral follicles in the ovaries, which determines the capacity of the ovary to provide oocytes that are capable of being fertilized. And this is a very important tool in the treatment of infertility. Now, think of ovarian reserve as your basket of eggs. Okay? So, as I've already mentioned a few slides back, at birth, we are only endowed a finite number of follicles. Okay, so it's about 3 to 4 million of follicles. Now, as we age, as you can see in this graph, our ovarian reserve also decreases until it reaches that critical level where there is already the end of fertility, and that is what we call menopausal stage. Now, ovarian reserve can be assessed by the following means. We can either determine it by using serum FSH, the antral follicle count, inhibin B, or the anti-Mullerian hormone. Okay, so the gold standard here will be a combination of anti-Mullerian hormone and the antral follicle count. The next event after the selection of the cohort is the selection of a dominant follicle. Now, usually only one follicle, or what we call the dominant follicle, is selected from the cohort to complete growth to maturity, while the other follicles in the cohort become atretic. Now you ask, how or why was the dominant follicle selected among all the other follicles in that cohort? Okay, the reason is because that dominant follicle is characterized by a well-vascularized theca layer, which allows a better access of the gonadotropins to their target receptors. And therefore, if the follicle is well vascularized, and therefore there's preferential delivery of the FSH and the LDL substrate. And of course, that dominant follicle also has more FSH receptors. Now remember that negative feedback loop that we talked about in the start of this lecture? So that is also one of the reasons why other members of that cohort became atretic and only the dominant follicle continued to grow. So recall the negative feedback loop that I already mentioned a few slides back. So as the follicle increases in size, it also produces estradiol. So the estradiol levels increase. And as the estradiol levels increase, it sends a negative feedback to the hypothalamus and pituitary. That also, in return, decreases the production of FSH. Now remember, FSH, as its name implies, stimulates the growth of the follicle. Now, as the estradiol levels increase, it sends a negative feedback to the hypothalamus and pituitary to decrease the FSH. And as the FSH decrease, of course, the FSH levels become insufficient to keep the smaller follicle from increasing in size. And therefore, if it doesn't increase in size, it will become atretic eventually. So and that's why only the dominant follicle can survive. Now, the last event in the follicular phase is the growth of the dominant follicle or the maturation of the secondary or antral follicle. Now, the maximum GnRH pulse frequency at this time of the follicular phase is about 1 GnRH pulse per 90 minutes. And this is the optimal pulse frequency to activate the proper gonadotropin response to increase steroid biosynthesis and the production of estradiol within the ovary. Now, remember this pulse frequency during the follicular phase because as you will note later in this lecture, during the luteal phase, we have a slower pulse frequency. Okay, so the main role of the gonadotropins and of locally produced estradiol is to continue to stimulate growth of the dominant follicle during the remainder of the follicular phase. An important change in the structure of the maturing follicles is the acquisition of the theca cell layer, which surrounds the granulosa layer and rapidly differentiates into the theca interna and the theca externa. So this is the theca layer here. Okay, so we have the theca externa and the theca interna. So this happens during the growth of the dominant follicle. Now, just a quick review of ovarian folliculogenesis. So, the growth of the primordial follicle up to its primary or preantral follicle stage is largely gonadotropin independent. What does that mean? It means that it does not need any gonadotropin or the influence of FSH to increase its size or develop into a primary or preantral follicle. Now, once it becomes a secondary or antral follicle, up to the stage where it becomes the pre-ovulatory follicle, now these stages are gonadotropin dependent, meaning it needs the help of FSH or the follicle stimulating hormone and the LH for it to grow and mature. Now, at this point, let me introduce to you the concept of two-cell to gonadotropin theory. So, this two-cell to gonadotropin is called as such because we have the two cells here, the theca cell and the granulosa cell, and two gonadotropins, which are the FSH and LH. So, this theory basically tells us about the production of, or the ovarian production of androgen and estradiol from, of course, the raw material, which is cholesterol. So, cholesterol diffuses through the theca cell or goes inside the theca cell to be converted to androstenedione or an androgen. And this is largely under the influence of LH. Alright? So once androstenedione is produced, it diffuses through the basement membrane or crosses the basement membrane to enter the granulosa cell, where it will be eventually converted to estradiol through the enzyme aromatase. And this conversion of androgen to estrogen is what we call aromatization, okay, from the word aromatase. And this conversion of androgen to estrogen inside the granulosa cell is largely under the influence of FSH. So that's the two-cell to gonadotropin theory. Now, the maturation of the dominant follicle is marked by high levels of estradiol. Okay, as I've already mentioned a few slides back, as the dominant follicle increases in size, the estradiol levels also increases. Okay, so once high levels of estradiol or the peak estradiol levels is already achieved, then a positive feedback loop signal is sent to the hypothalamus and anterior pituitary to bring about what we call the LH surge. Okay, so in this picture, we have the LH surge here, this blue line. Okay, so after the LH surge, we have ovulation. So what is actually the LH surge? Why is it important? The LH surge actually serves as the trigger. Okay, so this is also what we call the trigger. And this is an absolute requirement for the final maturation of the oocyte and, of course, the initiation of the follicular rupture. In other words, without the LH surge, we don't have ovulation because LH surge triggers ovulation or triggers follicular rupture. The LH surge initiates germinal vesicle or nucleus disruption, and the fully grown oocyte resumes meiosis or what we call meiotic maturation. It progresses from the diplotin stage of the meiosis 1, which was initiated during fetal life, to metaphase 2 of the second meiotic division. During ovulation, meiosis is arrested again, and this is what we call the second meiotic arrest. The second meiotic division will only be completed at the time of fertilization. Now, after the follicular phase, we have ovulation. So, ovulation or the follicular rupture occurs about 32 hours after the initial rise of the LH surge and about 16 hours after its peak. LH surge induces an acute inflammatory-like reaction. Of course, this is needed to induce follicular rupture. Follicular rupture is also due to the following factors. We have prostaglandins that induce hyperemia and edema that result from increased blood flow and vascular permeability. We have the proteases that leads to degradation of the follicular layers and the wall. And lastly, we also have plasmin, which helps in detaching the cumulus cell enclosed oocyte from the granulosa cells, which initiates the process of extrusion of the oocyte and cumulus. Now, what happens in the endometrium during the first half of the cycle, which we also call the proliferative phase because we already are talking about the endometrial cycle? Okay, immediately after menstruation, the endometrium is only 1 to 2 centimeters or 1 to 2 millimeters thick and consists mainly of the stratum basale and a few glands. Okay, so as the estradiol levels increase, the stratum functionally proliferates greatly by multiplication of both glandular and stromal cells. So there's increase in the mitotic activity due to the rising estrogen levels. Now, towards the late follicular phase, the straight glands become progressively more voluminous and tortuous. In other words, during the proliferative phase, the endometrial or the endometrium proliferates or increases in thickness. Okay, that's what basically happens during the first half of the cycle or the proliferative phase in the endometrium. So at the time of onset of the LH surge and before ovulation, subnuclear vacuoles appear at the base of the cells lining the glands. Now, these are the first indication of an effect of progesterone, reflecting the small but significant increase in progesterone seen during this time. Endometrial thickness increases from a mean of about 4 millimeters at the start of the proliferative phase to 12 millimeters at the time of ovulation. Now let's talk about the second half of the menstrual cycle, or what we call the luteal or secretory phase. Now, the luteal phase is mainly characterized by the formation of the corpus luteum. Now, the corpus luteum is the result of two important events initiated at ovulation. First is granulosa and theca cells hypertrophy. So there's increase in the lipids and they acquire organelles associated with steroidogenesis. And the basal lamina is also disrupted and capillaries from the theca interna invade the granulosa layer to form an extensive capillary network. So as you can see in this picture, so the corpus luteum is colored yellow, and yellow means fats. Okay, so it is full of lipids, and as you can see here, not only is it colored yellow, it is also colored red or pink, which means that it has an extensive capillary network. Now, the hallmark of the corpus luteum is its secretion primarily of progesterone. This is the reason why during the second half of the cycle, we have the predominant hormone as progesterone. So here we see a progesterone increase, okay, relative to the other hormones. Okay, and progesterone is mainly produced by the corpus luteum. Now, the normal function of the corpus luteum depends on LH stimulation throughout the luteal phase. Now, during the luteal phase, there is progressive slowing down of LH pulse frequency from 1 pulse per 90 minutes at the beginning of the luteal phase to 1 pulse every 3 hours. Okay, so as I've already mentioned a few slides back, during the second half of the cycle, there is a slowing down of the pulse frequency as compared to the first half of the cycle where we have a more rapid pulse frequency. Progesterone dominance during the luteal phase affects hypothalamic thermoregulatory center, and this is also manifested as increase in the basal body temperature, mainly because progesterone is highly thermogenic. Now, as I've already mentioned, lifespan of the corpus luteum is limited or fixed to a period of about 14 days, and that is also the reason why the second half of the menstrual cycle, which is the secretory or the luteal phase, is also 14 days. The corpus luteum reaches maturity 8 to 9 days after ovulation, after which time luteal cells start to degenerate and its secretory capability begins to decline. Only rapidly rising concentrations of chorionic gonadotropin, or what we call HCG, which is secreted by the syncytial trophoblast following conception or following fertilization, can rescue the corpus luteum and maintain the production of progesterone. Meaning, if the patient becomes pregnant, then the corpus luteum does not undergo regression. Okay, so if the patient becomes pregnant, the corpus luteum is rescued and it is needed to maintain the production of progesterone. You know for a fact that progesterone is very, very important in the maintenance of pregnancy, especially in the first few weeks of pregnancy when the placenta is not yet fully formed. So you need the corpus luteum, or you need to maintain that corpus luteum so that the production of progesterone is maintained in the early weeks of pregnancy. Now, what happens now in the endometrium during the second half of the menstrual cycle, or what we call the secretory phase? Well-developed subnuclear glycogen-rich vacuoles appear in every cell of a given gland, and this correlates with the total lack of mitosis in all glands. Okay, so progesterone antagonizes the mitotic action of estradiol by decreasing estrogen receptors and by increasing progesterone-specific enzyme 17-beta hydroxydehydrogenase, which converts estradiol into the much less active estrone. So remember, during the first half of the menstrual cycle, or what we call the proliferative phase, the endometrium increases in thickness. Okay, so in the second half of the menstrual cycle or the secretory phase, the endometrium does not increase in thickness, okay, because progesterone antagonizes the mitotic action of estradiol. The contents of the endometrial glands are released into the endometrial cavity, and this coincides with the arrival of the free-floating blastocyst, which reaches the uterine cavity by about 3.5 days after fertilization. Now, this release of glycogen-rich nutrients is very important or crucial because it provides energy to the energy-starved free-floating blastocyst. The window of implantation is typically defined as days 20 to 24 of a 28-day menstrual cycle, with implantation occurring about 1 week after fertilization. Now, lastly, we have the menstrual phase. So, if implantation of the blastocyst does not occur and human chorionic gonadotropin is not produced to maintain the corpus luteum, so we have endometrial glands beginning to collapse and fragment, no? And this is what we call menstruation. This results from intense tissue breakdown by proteolytic enzymes, mainly members of the matrix metalloproteinase family or the MMPs, and that these enzymes are stimulated by the products of an inflammatory process. The degrading actions of the MMPs lead to the destruction of endometrial interstitial matrix and the resultant bleeding characteristic of menstruation. As you recall, no, regular menstruation usually lasts only for 3 to 5 days. Normal range is about 2 to 7 days. And the average blood loss per cycle is about 35 ml, normal range of about 10 to 80 ml. The enzyme plasmin tends to inhibit the blood from clotting. And because of the blood loss, premenopausal women have higher dietary requirements for iron to prevent iron deficiency. So that's it for my lecture. So in summary, we have talked about the different phases of the menstrual cycle. So the first half of the menstrual cycle is what we call proliferative or follicular phase. And this is where mainly follicular growth happens. And the predominant hormone during the first half of the menstrual cycle is estrogen. The second half of the menstrual cycle is what we call the secretory or luteal phase. And this is where the corpus luteum is formed. And therefore, since it produces progesterone, progesterone is the predominant hormone during this second half of the cycle. So thank you for watching this lecture, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you.